Rural America is in a crisis. A spike in suicide and death by substance abuse has strained communities already struggling with a lack of clinical and inpatient resources. But there is hope. Led by their local health systems, two rural communities in Colorado and North Carolina have rallied to meet the challenge, and they're changing the fortunes of those that live and work there. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly with AHA Communications. In this two-part series, we learn how two rural communities are developing new and innovative solutions to build capacity for behavioral health services. Part 1 deals with solving the Paradise Paradox and stemming the surge of suicides in Eagle River Valley, Colorado. Part 2 is the story of how navigating a complex bureaucracy increased the inpatient psychiatric bed capacity of a critical access hospital in New Avery County, North Carolina. In today's Part 2 podcast, John Supplitt, Senior Director of Rural Health Services with AHA, and Jordan Steiger, Senior Program Manager, AHA Clinical Affairs and Workforce, are joined by Stephanie Greer, President of Cannon Memorial Hospital in Newland, North Carolina. Cannon Memorial succeeded in obtaining an unprecedented Medicare waiver that allowed it to expand the inpatient capacity for psychiatric services in the community. Let's hear about the difference it made.
Good day. I'm John Supplitt, Senior Director of Rural Health Services for the American Hospital Association. I'm joined by my colleague Jordan Steiger, Senior Program Manager, AHA Clinical Affairs and Workforce. Welcome, Jordan. To address our concern regarding the incidence of mental illness and our capacity to treat it, we present a podcast in two parts. In part 1, we reviewed some rather staggering statistics on the incidence of mental illness in rural America. That is, a recent survey by the Substance Abuse and Mental Health Services Administration, or SAMHSA, shows over 20%, or approximately 7.7 million rural adults, reported having any mental illness in 2020. In addition, 1.8 million, or 4.8% of adults in rural areas, reported having serious thoughts of suicide during the year. This is a crisis of enormous proportions and one that requires new strategies to address the growing demands of those living in rural America. Jordan, your thoughts?
Wow, John, indeed it is. Those are shocking numbers that demand our immediate attention. So you will recall that in part 1 of this podcast series, we heard from Will Cook, who is the president and CEO of Vail Health in Vail, Colorado, which serves Eagle and Summit counties in Colorado, where residents and healthcare providers were confronted by a surge of suicides and the need for an immediate remedy in their community. Today, in part 2, we hear a story from Stephanie Greer, who is the president of Cannon Memorial Hospital, an Appalachian Regional Behavioral Health Hospital in Newland, North Carolina, where Appalachian Regional Healthcare acquired an unprecedented waiver in Medicare conditions of participation to expand the inpatient capacity for psychiatric services in the community. Stephanie, welcome to the podcast. Thank you very much for sharing your story with us today.
Thank you for having me.
So I'll set the stage. In November 2021, leaders at Charles A. Cannon Jr. Memorial Hospital formed Appalachian Regional Behavioral Health Hospital, which is a 37-bed walk-in inpatient facility and the first ever critical access hospital in the country to also house a behavioral health hospital on its campus. So Stephanie, tell us a little bit about what motivated this change and how did this all come to be?
Well, I'll start by telling you a little bit about the history of our critical access hospital and the services in this rural community. Cannon Memorial Hospital was actually built in 1999 following the merger of two very rural, smaller hospitals. In 2005, we converted Cannon Memorial Hospital to critical access status, and at the time maximized all of the capacity available for a critical access hospital. We had 25 inpatient beds, a fully functioning emergency department, OB services, CCU, med-surg, outpatient services. We even had a 10-bed restorative care unit associated with that. But over time, we saw a significant decline in the use of those services. And I think a lot of critical access hospitals across the country have seen similar declines. So in 2008, we actually opened a 10-bed distinct part unit that was a behavioral health unit associated with Cannon Memorial Hospital, because we had started seeing the influx of patients to our emergency departments and no placement options available to them. It's also important to note that in rural America, there's not a lot of resources available on the outpatient side. So people often didn't have any option until they got to a crisis point and required a level of emergency intervention. So we opened that in 2008. Subsequent to that, we continued to see a decline in utilization on the traditional medical side of things. We ultimately closed our restorative care unit. We closed OB services. We closed the critical care unit. And we got to a point where we were at an average daily census of 4, which is shocking, I think, to some. In the same time frame, our 10-bed behavioral health unit had a bed empty to bed fill time of less than 3 hours. Our 10-bed unit had an average daily census of 9.7 because it's based on the so powerful midnight census. We were receiving thousands of referrals a year, taking patients from across the state, and recognize that the model we had in place wasn't meeting the needs of our community as our community had changed and shifted. So that prompted the desire to right size and to figure out a way that we could maintain the critical access status, because in rural areas, that's so important, right? The federal reimbursement is different. It's not sustainable any other way, but to meet the crisis needs of those behavioral health patients in our region. And as a result, we reached out to CMS for the unprecedented exception that John mentioned before, and we did obtain an exception from CMS around a co-location rule. Those of you that are familiar with critical access conditions of participation, you're not allowed to have a critical access hospital within 35 miles of another hospital or 15 miles of mountainous terrain. But because it was a behavioral health hospital, CMS granted us that exception, and then the story just unfolded.
It sounds like you might have encountered a few bureaucratic hurdles along the way getting this designation. So could you tell us a little bit about that?
Absolutely. It truly seemed like every other day was a different hurdle to jump over, but we are very fortunate in the power of community and power of creative leadership in our state. So we ultimately rallied other stakeholders, law enforcement, politicians, other behavioral health providers, other hospital providers to work through this to the point even North Carolina Medicaid got involved and changed a definition for a Medicaid rule that would allow us to begin billing for these services in this new facility in a way that they'd never allowed before. The North Carolina Hospital Association was absolutely instrumental through that entire process at connecting hospital leaders here on this site to leaders at the state level with DHHS and Medicaid and other influential people, simply to give us an opportunity to tell our story. At the end of the day, we wanted to take care of patients. We wanted to protect traditional rural health care, and we wanted to meet the need of the behavioral health crisis in our state. And once we had the opportunity to tell that story, all of those bureaucratic barriers seemed to start melting away. I won't tell you that it wasn't without challenge and that it did not require a level of tenacity, but I think in general, people want to do the right thing. Agencies want to do the right thing. They want to meet the need. And so at the end of the day, we received a tremendous amount of support at the federal, state, and local level in accomplishing this brand new model of care.
And it's an incredible achievement, I think, to be the first and the trailblazer really in the country for this new model of care. And I love what you mentioned about responding to the needs of your community. I think especially for behavioral health, it's just so important. Could you tell us a little bit now about what the outcome of all this effort has been and how everything is going?
Sure. So it's important to note that because it's a co-location model, we were able to share all of our ancillary services. So in a freestanding facility, you're required to meet the conditions of participation for a freestanding facility. But because we are literally side by side with each other, all of the services like pharmacy and radiology and imaging and lab and plant operations and nutritional services are shared between the two, between the critical access hospital and the behavioral health hospital. What that did on the behavioral health side was give us an opportunity to provide the required level of structure and services for a freestanding facility. But the real power in the model is that in a facility on our critical access side where we didn't have enough volumes to appropriately sustain 24/7 care and all of those ancillary services, the additional volume created by the behavioral health hospital created the bandwidth we needed. We didn't have to add positions in those ancillary departments. We were just able to fill out their service gaps in a meaningful way. And I think it gave us an opportunity to establish a lot of efficiencies that we wouldn't have otherwise. The opportunity to share resources then creates a bit of a snowball where you start sharing other clinical resources. And in a small rural setting like ours, it's absolutely imperative that you take every possible creative approach around staffing, around supplies, around, all of those significant expenses that you incur as a hospital. And we've been able to gain some efficiencies and some economies of scale in that. It also created 60 new jobs in an environment that I'm told, this has not been validated, I'm told hasn't happened since the 60s in this area. So with that said, staffing and recruitment has certainly been another one of those challenges that I think people are facing across the country. We've filled about 50 of the 60 positions that we've had to date, but it has given career path opportunities to local residents who historically didn't feel like there were career opportunities in the area. It's created stronger partnerships with different agencies, from the health department to law enforcement to the court system on both sides of campus. It's just truly been a beautiful thing to watch unfold and to see. It's brought life into this campus. Sometimes it's easy to compare what the parking lot looked like 4 years ago and what it looks like now. And it went from very little movement and activity to a booming filled parking lot. The other thing that happened with the appropriate use of our ancillary services is that it created enough bandwidth that then we could start adding additional outpatient services back to the traditional medical side of things. So we have increased our ultrasound services. We've increased CT. We're bringing MRI back, and this campus has not had that in years. So it's a powerful story to see unfold. We're still in the initial stages of that. We opened our behavioral health hospital on November 15th, 2021. So we're getting ready to hit the 1-year mark. But it has been a shocking shift in the culture, in the volume, and in the economies that we've gained.
Lots of positive outcomes, it sounds like, for your hospital and for your community. So as you come up to this 1-year mark for the behavioral health hospital and your services, what have you learned from this experience that you can share with listeners who might be interested in following in your footsteps?
Absolutely. I think first and foremost, to be not only very comfortable, but very excited about engaging other stakeholders. So I think sometimes as hospitals in particular, we think we're on an island, or we're on an island only with other hospitals, when the reality is, particularly in rural America, we're all serving the same people, right? So if you can immediately engage the other stakeholders, other agencies, whether even urgent care centers, outpatient centers, diagnostic services, law enforcement, court systems, all of those components in the early stages, to get perceptions and feedback and identification of need, because what may have been a priority here in this small town in North Carolina might not be the same priority in every small town across the country. So it's important to start that dialogue. It is important, I mentioned it before, but it is important to be tenacious. It's not easy paving the way in any capacity. And there's no one, or at least there hasn't been for us, obviously, to say, here's best practice, here's best model of care. So I think to kind of recognize that up front and be willing to face that. Now, we are open here to answer any questions from any other entity or agency that's interested in exploring this further. But I am sure, and this is my last point, I'm sure that there's more to learn. And I think that's the final point in that, to be flexible enough and agile enough to be in continual learning mode as you unfold these processes and evaluate the needs. If you've done that pre-work with the agencies and if you've done that work with your community, it's relatively easy to then pretty much on the fly, as you need to, say, hey, what we thought was appropriate and necessary wasn't the best course of action. So we're going to shift here. And we had to do that a few different times, right? But I think that also creates that spirit of teamwork and ownership. From a behavioral health perspective, we want our community to feel ownership of behavioral health services. We briefly touched on the walk-in option to our behavioral health hospital, but I can't stress enough how impactful that has been to create an opportunity for people to self-present without having to go through an emergency department. And that is only available because of our co-location model. The lab comes to ARBH and imaging comes to ARBH, and all of those services that historically kind of mandate that people go somewhere else to get medical clearance, because psychiatric hospitals are not equipped to do medical intervention and assessment at the same level. It just creates a symbiotic approach to that in a way that a human being can connect immediately with the clinical expertise on the behavioral health side of things, and we can still assure that they're medically safe to be in a psychiatric setting. So I think it's those 3 points, honestly. And I'm sure if you asked me that question this time next year, I would have a few more to say or to share. But that's where we are today.
Well, maybe next year we'll have to do a follow-up podcast and see what your next 3 points are. Stephanie, this is a remarkable story. We're so excited to share this with our membership and just really feel like there's so much that people can learn, especially our rural members and our critical access hospital members. So thank you so much for sharing this with us today. I'm going to hand everything back off to my colleague, John.
Thank you very much, Jordan. Many rural communities struggle with delivering essential behavioral and mental health services in their community. This is a persistent problem that requires innovative approaches to resolve. We've heard from the leaders of 2 rural communities that have taken action to build behavioral health capacity by collaborating with area businesses, community groups, mental health providers, first responders, law enforcement, and government entities to supply necessary resources to address the profound demand for behavioral and mental health care. Thanks very much to our expert faculty, Stephanie Greer, President and CEO, Cannon Memorial Hospital, an Appalachian Regional Behavioral Health Hospital in Newland, North Carolina, and Will Cook, CEO, Vail Health, Vail, Colorado. The strength of our rural healthcare is critical to the fabric of American healthcare, and it is our mission to safeguard it, improve it, and expand it, and advance it for future generations. Thank you to our country's hospital and health system leaders like Will and Stephanie, and the board members, nurses, physicians, social workers, counselors, and all the healthcare heroes caring for the community in and across rural America. This is one of several stories of how rural hospitals are rising to the challenge to transform healthcare and introduce innovations to improve the health of their communities. Visit www.aha.org to access these and other resources available to hospitals and health systems. Thank you for listening. I'm John Supplitt, and this has been an AHA Advancing Health podcast.